In this video, we will describe our technique to the superolateral approach to knee aspirations.
Indications for knee aspirations can be diagnostic or therapeutic. Diagnostic reasons include the diagnosis of septic arthritis, crystalline arthropathies. Therapeutic reasons are for pain control with large fusions, which can be combined with a lidocaine injection for injuries such as an ACL rupture or patellar tendon rupture. There are various portals of accessing the knee joint. The anterolateral and anteromedial portals are described in separate videos. In this video, we will describe the superolateral portal, which we consider the best portal for aspirations in the native knee, as well as an excellent alternative for knee injections. There are several risks to knee aspiration, such as infection, cartilage damage from the needle, bleeding, lidocaine toxicity from the therapeutic lidocaine injection, which can be avoided with an aspiration of the syringe prior to injecting any lidocaine to ensure you are not in a vascular structure. It is important to ensure you have gathered all your supplies prior to performing the procedure. For aspirations, we prefer to have 20 cc's of 1 to 2% lidocaine without epinephrine, an ethyl chloride topical spray, an alternative of which can be a LMX topical lidocaine cream, one 18-gauge needle, which is preferred for aspirations, as small needles can become clogged or clotted off during the aspiration. 21 to 23-gauge needles are preferred for the skin anesthetizing with lidocaine. A 20 cc syringe is needed, as well as a large syringe for aspiration, which can be anywhere from a single 20 cc syringe to multiple 50 cc syringes depending on the size and volume of the effusion. If being performed for diagnostic reasons, aspiration collection containers are required. At our institution, this includes a lavender top tube for cell count and crystals, as well as a sterile collection vessel without additives, such as a urine specimen cup for cultures. ChloraPrep cleaning sticks and dressing supplies following the procedure are also required. First step of the procedure involves appropriate setup, performing an informed consent, and a timeout. For our knee aspirations from the superolateral portal, we prefer the patient to be supine. You can use a bump under the ipsilateral hip to assist with internal rotation of the leg for ease of access to the superolateral portal. And again, it is important to assemble all supplies to prevent delays during the procedure. We prefer to mark out the appropriate landmarks, which include the borders of the patella, the patellar tendon, tibiotubercle, the anterolateral and anteromedial soft spots for alternative aspiration sites if unsuccessful aspiration is performed from the superolateral portal, as well as marking our superolateral portal, which is in between the superolateral patella and the lateral femoral condyle. A helpful tip can be to milk the effusion from the medial side of the knee laterally to assist in portal placement. Next, you apply a topical ethyl chloride spray to the intended aspiration area and perform a sterile prep of the intended aspiration area with ChloraPrep sticks. Next, we anesthetize the aspiration site. A 20 cc syringe with 1 to 2% lidocaine without epinephrine is used, and a 21 to 25 gauge needle to prevent pain to the patient is used as well. Inject the aspiration site skin and subcutaneous area with around 5 cc's of lidocaine and save the remainder for the lidocaine block at the end. A helpful tip in aspirations in all areas of the body is that once you inject lidocaine into the skin, follow the area of white discoloration with your needle to avoid continued discomfort to the patient of advancing a needle through unanesthetized skin. Next, plan your intended trajectory from the superolateral skin to the suprapatellar pouch, and then perform your aspiration. You want to aim between the patella and lateral femoral condyle. To help, you can push the patella laterally to make sliding the needle underneath easier. When going in, you should feel 2 losses of resistance, first at the skin, and second at the knee capsule as you enter the knee joint. If you feel a hard stop prior to this, adjust your trajectory. If you find that you're hitting patella, raise your hand to slide the needle inferior to the patella. If you find you're hitting femur or trochlea, lower your hand to raise the needle up over the trochlea. Once you're in the knee joint, perform the aspiration. As you're drawing back fluid, you may need to adjust the needle position as fluid is aspirated and soft tissue blocks the needle tip. As shown in the top picture, you can milk the effusion to assist in the aspiration. Once all fluid from the knee has been aspirated, you can detach the aspiration syringe, inject at least 3 cc's into the lavender tube for cell count and crystals, as not much volume is needed for those studies, and inject the remainder that you have into a sterile container for cultures as more fluid is required for those studies. Attach the remainder of the 20 cc lidocaine syringe that you had saved from the skin anesthetizing back to the 18-gauge needle in the knee joint. Aspirate back to ensure you're not in a vascular structure, and then inject the remainder of lidocaine into the knee joint for pain control. This should flow smoothly without resistance. Following aspiration, hold manual compression on the injection site to prevent bleeding. Dress the aspiration site with a Band-Aid or gauze and tape or a special dressing. And then for the specific pathology involved, perform the appropriate immobilization or comfort care. For example, for patella fractures, we prefer to place patients in a bulky Jones dressing and a knee immobilizer versus a hinge knee brace lock and extension. Here's a video demonstrating our superolateral aspiration. You can see the patient is positioned supine with a patella facing superiorly to the ceiling, not in external rotation. The sites are appropriately marked as described. Most important is the superior and lateral pole of the patella, and the superolateral portal is marked. The skin is sprayed with ethyl chloride spray to prevent discomfort from the lidocaine injection. The skin is then prepped with ChloraPrep sticks. Next, the skin is injected with 1 to 2% lidocaine without epinephrine, and then the knee is aspirated. Feel lateral pole of patella. It is helpful to move the patella over laterally and then to slide the needle underneath the patella between femur and patella to ensure you are in the knee joint. Begin your aspiration, and it's very common to require some mobilization of the needle as soft tissue can block the needle portal. Again, a helpful tip is to milk the medial side of the knee to push the effusion into the suprapatellar pouch laterally to aid in your aspiration.
When aspirating for infection, there is no need for a lidocaine injection following aspiration, unlike in this case for fracture analgesia.
In this case, a 20 cc syringe was used, and about 10 cc's of hematoma from this patient's patellar fracture was aspirated. Detach the aspiration syringe while leaving the 18-gauge needle in the knee joint, and then attach the remaining lidocaine from the skin anesthetizing to the 18-gauge needle, and inject the remaining lidocaine into the knee joint for analgesia. The aspirate can then be injected into the appropriate collection containers to be sent for appropriate diagnostic studies. Withdraw the needle and compress the aspiration site.